Happy Friday, everyone. This is Ray Pedden from the Center for Care Innovations. Welcome to CCI's Raven e-learning series. The Raven e-learning series has been developed to highlight technology solutions.
A little more in that grant. We were involved in a NAC Prepare grant where NAC was taking a pilot that they had done a couple of years ago and wanting to engage some health centers in California to spread the assessment of social determinants of health. We had a Robert Wood Johnson grant for complex care where we were assessing for social determinants, and then a county grant. And I say all that because you know, you need funding in order to engage in this work. So that was really instrumental for us. So in 2016 and 17, we really worked on gaining our health centers, our shareholders' interest in buy-in to start collecting this data in a more consistent and standardized way. So you can see here on this first page that we formed a social determinants of health work group. We invited all of our members to participate in the group, and these were really the early adopters for collecting social determinants data. We really wanted to figure out a way to identify and agree upon a standard tool and standard questions to ask and standard answers that we could then document it in our health systems in structured data. We did a crosswalk of a bunch of different assessment tools, Prepare, Institute of Medicine, Kaiser, and some homegrown approaches that 2 of our health centers had already started to develop on their own. And in 3 or so meetings, we agreed to adopt the core elements of the Prepare Pair assessment. And that's essentially a set of 17 core questions and 4 optional questions. And many of our health centers were asking about half of them already. So it was a doable lift. So RCHC supported our health centers in building out their EHR templates to collect the data and map some of the data, and gave them some pass-through funds for some smart forms to start collecting the data. We also helped with them kind of figuring out what the possible workflows to adopt this work was. Did some trainings. We partnered and brought the Oregon Primary Care Association down to talk about the workflows and the things that they had been doing to start this work. So really our objective was to just get them going, get started, pilot with a target population, and start collecting the data. We did have sort of a back and forth with the health centers in terms of hesitancy in kind of the chicken and the egg conversation between, you know, not wanting to collect the data and not having a place to go with it. So we did, fortunately, and Dr. Oren can speak to this, have 2 health centers that were already using a product, piloting another platform. And so they could bring that information to the table and sort of talk about that experience as there are tools that we can use to, once we have the data, connect patients to social services. So we started in that realm and we began assessing the data. We did train the trainers using the platform that the 2 health centers had already been engaged in, and we got some traction going. At the end of the pilot that we had with the prior platform, which was in August of 2017, we secured some additional funding for a resource directory to carry us through to the end of 2019. So we did a scan of the marketplace and looked at the solutions that were available, and pretty much did an assessment of 6 community resource and referral platforms over a 6-month period. And in June of 2018, we partnered with Aunt Bertha, and really want to acknowledge Ray's role in helping us with negotiations and working through that process. It was great. And Aaron's team has been super in terms of, you know, starting the project that we have. So as you can see now, where we are is you see some stats on the back. We're really quantifying how we're doing with the Prepare tool. We're at 60 or 8,600 surveys done by 9 health centers. We are implementing on Bertha. We have rebranded it locally to be called NorCal Resources. And we're starting in Sonoma County with the intention of going to Yola, Napa, and Marin. Lillian is on staff here, is our coordinator who's hitting the streets and collaborating with our partner community benefit organizations and our health centers to show and tell, show them the product and get them to claim their resource. It's a lot of work. And we're working on strengthening our partnerships with our community agencies, securing funding, talking a lot about data sharing and compliance, and really with the intention to eventually be able to aggregate the data that we're getting from this platform. And I think that's where I'll stop.
Any questions from the group? Let me then move on to our next faculty. Diana, you want to take it over from here?
Sure, thank you, Ray. So this is Diana Griffin from Aunt Bertha. If you want to move to the next slide. I'll start by speaking about our process at Aunt Bertha around developing and validating the community resource directory. On the next slide, the 2 topics that I want to talk about are both building that community resource directory and ensuring that it's accurate and useful, so maintaining the data over time. The next slide shows, just to set the stage around our approach to building that directory, Aunt Bertha provides a nationwide database of community resources. We have over 1.5 million users and growing as of today. And this includes programs offering services at the local, state, and national level. And I'll maybe just pause here. If anyone is on the line and can mute their line while I'm speaking, that would be helpful. I'm getting a bit of feedback here. Great, thank you. So we invest in building our resource database and making it accessible for patients and community members to self-serve. And we do that to expand the reach of your care teams. You can see on this chart, what I'm describing here is that when your staff, the community-based organizations they work with, the patients and the families they serve, can all access the same resources and close the loop through the same platform, the opportunity for impact is that much higher. On the next slide, I'll describe to build and support that resource directory, which enables that expanded reach. We have an in-house team at Aunt Bertha of over 20 people who are dedicated to keeping this information current. Every single program in our database has been researched by one of our team members. So our partners and our clients can think of this team as your outsourced data operations team. On the next slide, to support this team's work, we also have a multi-pronged approach that includes automated processes as well as the opportunity for input from platform users. Local and national CBOs often suggest and make changes as well through our intake management suite. On the next slide. And this intake management suite is free for CBOs to use. It allows them to update their service offerings and capacity information, as well as providing a number of tools to support different channels for patients to connect and take the next step to access services. These tools are all designed to meet CBOs where they are, understanding that different organizations have different processes and workflows in place, different resources available, and we want to give them options to incorporate into a variety of workflows, all of that leading to closed loop referrals. And on that note, I can pass it to Danielle to share her perspective on community referrals from the provider perspective.
Sure. So I don't have any slides to share with you, but I'm going to share a little bit about my experience at Petaluma Health Center in terms of what the closed loop referral system has been like for us. So at Petaluma Health Center, we were part of the pilot with another community resource directory prior to the NorCal resources. So I'm going to really refer to my experience with that more so than our current, because we haven't yet used the closed loop referral with Aunt Bertha yet, but I think that the experience is the same. I think it's really interesting because and I think as Teresa kind of alluded to, there's this tension that is between, you know, asking people the questions and having resources to refer them to. And in some of those conversations at the coalition, there's even a feeling of how can we refer people to someplace if we can't get information back? And so definitely as we were working on this, the closed loop referral feature became really important. My experience, though, at the health center was that having the ability to close the loop on referrals doesn't necessarily mean that we want to close every loop on every referral. So first of all, our first learning in working with our very first partner, Petaluma People Services, was that we didn't work on what our communication would be like ahead of time. We just said, okay, we're going to send you the referral electronically and you're going to respond back. And what we got was, on both sides, not a lot of great communication. So we didn't decide ahead of time, here are the things that we want to know, and here are the things that you need to know back about what happens with these clients, patients, depending on who you're talking to. And so we would get these, the person didn't come messages, and like, that's not super helpful on the end of the provider or clinic. So from that, we actually, I think the learning that we took away was that it really takes, it's not just having a feature in a system, but really that feature has to reflect the relationship and the communication pattern that you've worked on with that other organization. So, you know, I think it's another example of where just the technology without the people in the process in solid, good place is not that helpful. So we did a lot of work to bring those referrals up to a place where our closed loop communication was much more meaningful. I think the other kind of key takeaway was, you know, getting back to this idea again that not every single referral needs to be a closed loop. So it made us think critically at Petaluma Health Center, okay, if we're going to have closed loop referrals and we're going to work on these relationships, which are those organizations that we feel are key partners in such a way that we are ready to work on that relationship and communication to have the closed loop referrals, and where is there really kind of a benefit to the patient or a decrease in the risk that the health center is taking when we have a closed loop. So if I'm sending someone to a local gym and I'm a clinical provider, which I am, I don't really want to know, I mean, it's nice if they go and I can ask them when they come back, but having to read a message about it is really kind of, you know, might be kind of silly. Whereas if I'm sending parents to, say, parenting classes because there's something going on in their home that's concerning, that closed loop referral actually is really helpful. So it led us to really think about what are the one or two next organizations we want to do this kind of work with to form the partnership that would create a meaningful closed loop referral in the long run. And then the last thing I'll say about it is just another kind of piece in terms of closing the loop on referrals. It did make us, you know, in our experience with it, made us wonder about, you know, we have this whole, we're going to ask the end organization, did you go? And all we can really find out there is yes, and if it's a no, we don't know anything more. So doing this work also led us to think about maybe it makes more sense sometimes to actually close the loop with the patients themselves. So rather than always having to close the loop, in certain circumstances, it might make much more sense to ask patients, did you go, rather than asking the other organization. So I think that's all I'll share from my perspective.
Any questions from our group at this point?
Well, I'm wondering if there's been any experience of someone, or maybe this is just eliminated by, because you have the right, groups involved, but if people have been sent to something where the service was not what you thought it was going to be, or not as good, or maybe they were turned away or told it was not available, if that has ever happened.
Yeah, I don't have a specific example around that, but I'm 100% sure that's happened. I think though that what we're working to do as part of this Bertha project is to really make sure that we reflect the key, requirements for a particular service or community-based organization engagement on the system, so that we don't refer patients who are not, who may not meet qualifications. And then sometimes, the experience isn't what we expect it to be. Like maybe they meet all the requirements and they get the service and it wasn't, as awesome as we hoped it to be, in which case some of the features in these systems can be really helpful, like rating systems and kind of notebook features that allow you to make comments to say, hey, if you're expecting that this place is going to cook meals for the person every day, they're not, they're going to show them how to cook, whatever it is, right? To clarify that experience so that the other navigators, providers, medical assistants, whoever it is that's doing the referring can use that information in making the next referral.
Thanks.
Diana, back to you.
Oh, can I add one thing? Lily just made a comment that I'm going to repeat, or she can repeat it. Why don't you repeat it since you're here?
I've been doing the outreach with CEOs, engaging them into using the product and claiming the product. One of the key features that really entices them to claim is the pre-screening tools. So they have the option to select certain questions for their particular program. And that'll pop up to whoever's referring a patient or whoever's using the system for a referring process. So just wanted to highlight that.
Thanks, Lily. That's great. So Ray, if you pass me the presenter, then I will jump into the product for a demonstration here.
Okay, you can share your screen.
Great.
Should be a green button down at the bottom of the Zoom screen. There we go.
There we go. So in the interest of time today, I won't dive into very nuanced details about the functionality. But what I do want to walk through is high level, the workflow that Teresa referenced earlier, starting with the prepare assessment. So I won't make you watch me go through and fill out this form, but I've pulled it up and filled it. And going through, I've just identified some needs across different domains here. The reason I'm pulling this up is that when I do submit this form, what happens in the Bertha platform is I provide consent to save that, and when I submit, the form itself is actually looking at the responses and mapping those to resources in our directory. So that's able to refer to what was submitted on the form to generate search results according to the domains of need that were identified. If I jump into one of those domains, in this case the food, on that form I had identified as food insecurity, it will pull up search results based on what I said, based on what I explained on that form. Programs for food benefits, food pantry, other food sources are relevant to that search. Jumping into referrals, What I can see here is that this program that's at the top of the search results, I'll point out I'm on a demo site here, so this is a demo program. This was returned because on the prepare form, I answered that in the past year, I've been unable to get food when it was really needed, and this program helps pay for food. In order to refer a client or patient to that program, I can just go ahead and click the refer button. It will show, in this case, this program actually, again, it's a demo program. It's been claimed, and someone has updated it to indicate that they have a wait list. It's also calling out the eligibility criteria, so I know that when I'm making the referral. But because it's a demo program, I know I can go ahead and do this. So I'm going to pull up the information for the person that I just screened. That was Frida Friday on the prepare form. I can go ahead and set her contact reference, get consent to share this referral. And when I send this, it's doing three things. It's sending the program information to Frida. It's sending the information that Frida provided to the program, and it's saving a copy for myself as the navigator. So it's opening the loop by sending contact information to the program so that they could follow up with Frida. It's sending the program's contact information to Frida so that she can follow up with the program. And any party in that referral is able to close the loop. Very quickly, I'll walk into the navigator's view of that under People I'm Helping. From here, as I navigate, I can pull up Frida's profile. And you can see here, it's pulled in some of the information I submitted on the prepare form. So I could go and review the form. I could also go and review the search results that that form generated. But it's giving me the key information about Frida that I submitted, as well as identifying the domains of need that were called out on that form. And to manage the referral going forward, if I do want to close the loop with Frida, I can do so here by updating the status. Maybe next week I talk to her and she says that she contacted or attended this program and got help. I can update that status to reflect that here. When I do that, and I'm going to send it backwards through that status, this is reflected to both Frida, who, on her view of the referral, and to, in this case, the Bertha Community Foundation, the provider of that program, on their dashboard. Last thing I'll show here is that as I'm navigating with Frida, I may want to associate single referrals with an overall goal that I'm working on with her. In this case, I may want to say that this referral was related to her food goal, and that's going to move it up under her goal, so that I can start to build a picture of the navigation I'm doing over time. I won't spend too much more time on the navigator's view. Instead, what I'm going to do is jump over to the CBO's view. Again, I'm on a demo site and I'm logged in with an account that has both navigator and CBO features. But switching gears now to the CBO's view, where we can see what it looks like when the CBO receives that referral. So it was Bertha Groves was the program that I made the referral to. And you can see as it pulls up my dashboard here, this is pulling in information about the referrals received to this program. Again, it's a demo program and you're seeing demo information on the screen. But here's Frida Friday and the information that I provided about her, including her contact preference and the navigator who made the referral, as well as when the referral was made. This would be where the CBO can update that referral status, and you can see it's already got the update that I made from the navigator's view. Perhaps at the time, Frida needed to attend an appointment or visit the program. Now she has, and as the Bertha Groves Community Gardens program, I can confirm that she got help from this program. Again, that's updating for Frida herself, and in this case for Diana, the navigator. This is what we call a simple referral, where what we're seeing on the screen is just the basic information that was submitted with the referral. But what Lily referred to earlier was the option for a program to add additional information that comes in with a referral. That's an option where they can configure a form to be completed along with a referral. And when that referral is received, you'll see the form submitted. I can go and review additional information that was submitted. This is, again, a demo form and some example fields that can be collected, but this is all configurable by the program themselves. And that can allow them to get the additional eligibility information they need to take the next step, helping them get closer to triaging that inbound referral. One more thing that I'll point out here
Linda?
is,
sorry. Yeah.
Go ahead.
Sorry. Did you hear what I said earlier? I'm sorry.
Oh, sorry, I didn't.
Oh. Sorry. I was just saying, yeah. So I was just kind of sharing what they said, and so just so you're aware that they're trying to get a lot of clarification from Austin.
Sorry, clarification on what point?
Oh, I'm sorry. Hold on one sec. Sorry.
Was there a question or?
Go ahead, Diana.
Great, thank you. And we can pause for questions at the end as well. So the other tool that I wanted to point out while I've got this dashboard up, we've looked at simple referrals that just receive basic contact information, and we've also looked at the referrals that can be configured to receive additional information. A third tool that we have available is an appointment scheduling tool, where if the next step for someone seeking services is actually to make an appointment to come in, perhaps it's an intake appointment or an interview, that's something that the program can also configure on the site, and they can have their staff essentially record their availability, and those available appointment slots become bookable through the site. So as my calendar loads here, you can see I have a number of slots available and some of them are booked. And what this allows is that for someone on the site, I've just flipped over to a view where this program, you can see has the schedule button. When I click that, it brings me to a view where I can see this program at this location has appointments available tomorrow. I can select one of those appointment options and go straight ahead and book that time. Similar information being collected as what we saw on the referral. And that also includes a dashboard that is managed similarly to referrals. Just to keep things rolling here, I will pass it back to Ray so that we can continue, but are there any questions about what we've seen?
Hi, this is Deb Tran from Riverside. I don't know if you're going to discuss this later, but how do you provide for transportation for the patients to actually get, to these various appointments? Is that something that your clinic is helping with, or is the expectation on the patient themselves?
Teresa, I think that would be directed at you.
I'm actually in the process of onboarding a paratransit, a local paratransit organization, and there is a little bit of a hoop jumping because they work with a contractor, but we are getting that contractor and the paratransit together, and we're gonna train together on the CBO side, and they're gonna do the pre-screening tools to make sure that they get the correct type of patient. So that way, whoever's doing a case, whoever the case manager or the assister for transportation, they can do it all in one. They can say, okay, so you need to go to this place for housing. or so, they can try to include the transportation in possibly in that one appointment. That's the goal. So we're on the works of that.
And I think right now most health centers are kind of doing that work within their organizations as they always have. Whether they have taxi vouchers or some are aligning with lists, that sort of thing. I think what we're trying to do is bring those issues to the fore, that transportation is one of the top 3 items that we're seeing in terms of need. So what can we do based on, now we're going to have that data eventually to say, here it is, rather than just anecdotally saying this is an issue, so that we can kind of, use that information and foster some effort and some resources around that, so that, and maybe we approach that on a county by county basis, most likely, and to, kind of get some solutions around that.
Thank you.
And one question has come in through the chat. Elkin Salinas has asked Teresa, Dr. Oren, in your instance of Aunt Bertha, is that an enterprise solution developed by RCHC for participating clinics, or is the platform paid for and utilized by the CHCs individually directly, where RCHC is not providing any funding for the software?
Right. And it's definitely an enterprise solution that we contracted on behalf of 4 counties and an unlimited number of community benefit organizations claiming their program.
Thank you. Any other questions before we go back to Diana? You're up,
Great.
Diana.
I'll pass it back to you for the slides, Ray.
Oh, I got to find it here. Hang on a second. There you go.
Why do you keep going away?
Are we back?
That looks good. We're back.
Okay.
So I think next up was Teresa and Danielle sharing management and monitoring of non-medical referrals.
And I think Teresa and Danielle covered a part of this earlier on in terms of monitoring and managing the effectiveness, especially when Danielle outlined establishing some common communication standards between our community benefit organizations and our clinics. Anything else we need to add in that particular area, folks?
I don't think I have anything to add in that area. Maybe I don't think on a more macro level we are quite where we want to be in terms of, evaluating the effectiveness of individual referrals, but also looking at the larger system and making sure that our that the referrals that we're using are meeting the needs of our patients. I don't think we're quite there yet, but that's where we're looking to go.
So
Great.
that brings us back. Outcomes.
It does. So on the next slide, just within Aunt Bertha, when closed loop referrals are happening on the platform, we do have a robust enterprise reporting suite that does give the ability to track referral adoption across teams, and coupling that with cost data, of course, allows you to better manage health outcomes. One example that I have of that includes a partnership with the Health Exchange in Colorado. They partner with 53 agencies offering health coverage assistance services. And last year in the open enrollment period, those agencies recorded 18,000 appointments with their health coverage guides, all of that being recorded through Bertha. Because they were actively closing the loop in Aunt Bertha, we know that of those appointments, 14,000 people actually showed up. And even further, that roughly half of those appointments resulted in health coverage enrollment. So this is an example where an organizing organization, a central organization has built a partner network across agencies, and through that adoption, through that shared engagement, have brought together the data on closed loops that helps them inform their service provision and additional funding opportunities. And that's just one example that I'm drawing from some of the data in Bertha, but through our enterprise platform, there are honestly every click in the platform is tracked, and so we have a wealth of data that can be used to inform your KPIs and metrics.
Okay, we just had another question come in from Tanya Parker, who asks, what about the workflow of entering the information into Aunt Bertha? Is the information collected on paper with the client and then input at a later date, or is it done real time?
Do you want to take that, Diana, on how your clients do that typically, or do you want us to reply?
Sure. I can share broad examples, and then maybe your specific example would be great as well. But we have clients using a lot of different workflows. Our assessment functionality, so the prepare tool and other screening forms that can be set up, can be configured in a lot of different ways. So we have some clients who, for example, have patients self-serve on tablets in the waiting room. We have clients who are administering and entering the data through an interview with the client, having a staff member do that in the moment. And we do have some clients who are collecting the information on paper and then entering it after the fact. We also have clients who are coming from an EHR integration or other system and passing through some of their health record data into the form to pre-populate what they can.
So in summary, what I'm hearing is that the data entry can be tailored to the specific requirements of the instance that you're dealing with in the field, whether it be within the clinic itself, for instance, with our CHC moving the data from a prepare tool, data collection directly into getting services ordered and whatnot, and over the long term, as you iterate around that kind of an integration, it would get more and more closely aligned with the data that are already collected. Alternatively, it could be done on paper at the low fidelity end of the spectrum, and then used in the system, input into the system at a later date. Other questions? Well, a pretty silent group for a Friday. It's usually more rambunctious. Okay, Danielle, Teresa, RCHC, is there any last minute words of wisdom for the group who've attended for the last 3/4 of an hour?
I guess to me, the biggest help at the beginning of the journey was to just, start taking the steps, right? To not be paralyzed in this, we can't do this before we do that, that it's okay to start in either direction and start and the rest will follow.
I think we know,
Diana?
And we definitely,
sorry, Teresa.
No, I was just going to say, we definitely know, just to answer the person's question about kind of workflow, that it's going to vary. And so we're still trying to figure that out. I think we know there's a lot of things that we don't know yet, but we do believe in getting going and trying. So we're excited about implementing super strong over the next year.
I wanted to say something that it really does help having that, like for me, I feel like CBOs and health centers are more confident in the system when you have an individual like me going and making sure that the communication is there, making sure that if they can't figure out something, there's somebody that can reach out to.
Show them through the system.
Yep, great points. Diana, anything to add?
I'll just second everything that was just said. From our side, on the platform side, we really appreciate the opportunity to work with partners like our CHC and certainly to support them in building the network and building out this program and this process. And we're learning alongside them, but also excited to share our experience with other clients.
Well, I want to thank everybody for taking an hour out of their time on a busy Friday. Hope everybody's getting ready for a very, very happy holiday season as we go toward the end of the year. And I will look forward to our next e-learning session, which is coming up in January, and it'll be around management of interface engines, which is always an interesting topic to consider. Any last minute questions from the audience? Anything you'd like to bring up to our distinguished faculty, whom I'd like to thank profusely for spending the time with us today? Have a great weekend, everybody.
Thank you, Ray.
Thank you.